Hi, everybody. On November 2nd, we had our annual ELC Education Day. For those of you who don't know who I am Dr. Joshua Katz, and ELC is the Elliott Lewis Center. This is an MS center that's in Wellesley, Massachusetts, and if you're not a patient of ours, we'll include a link below and you can check us out. So every year we do an Education Day where we give talks, and we've had a lot of requests to post the talks online. So coming up is a summary of what I talked about that day. And I apologize in advance that the audio quality isn't optimal, but I did the best I could. Hope you enjoy it. So I got inspired to do this talk because people kept asking me, what's new in MS? What's the latest thing? And for a long time, I felt like there really wasn't anything all that new. We've been in this valley between having really effective treatments for relapsing MS, but waiting for the next big thing. But this year, at ECTRIMS, which was in Copenhagen, there were some really interesting presentations on one of the BTK inhibitors, tolebrutinib, and it looks like we might be on the verge of actually having effective treatments for progressive disease. And I wanted to introduce the idea of why BTK inhibitors might be effective for progressive MS by talking about progressive MS. And we have some of these questions that we still haven't been able to answer. Why has it been so hard to treat progressive MS? Why do our current disease-modifying therapies work for relapsing MS, but not really for progressive MS? What makes progressive MS different from relapsing MS? Is progressive MS different from relapsing MS? And if it is different, how are the biological processes driving progressive MS different? And are there treatments that might work? And so that was really the focus of my talk. You have two different immune systems, the adaptive immune system and the innate immune system. And we used to think that it was the adaptive immune system that was solely responsible for causing the problems in multiple sclerosis, but we now know that the innate immune system is involved as well. There are two types of inflammation that play a role in multiple sclerosis. There's acute inflammation, which starts outside the central nervous system. The adaptive immune system gets primed to recognize central nervous system myelin, and we see that B and T cells become activated and then cause acute demyelination and neuron loss. And that results in relapses and new MRI lesions that we see in people with relapsing MS. But there's also chronic inflammation, and this is inflammation that's compartmentalized inside the central nervous system, behind the blood-brain barrier, where our current disease-modifying therapies have a hard time getting to. And we see that this chronic inflammation involves both the innate and the adaptive immune system. We see activated microglia. We see that B and T cells at the edges of old lesions are active, and we also see collections of B cells in the meninges that leads to chronic demyelination and neuron loss. And in MS, we see that both of these types of inflammation occur at different stages of the disease, but they're both present to some degree at different points along the disease spectrum. Early in MS, there's more acute inflammation involving the adaptive immune system. But later in MS, we see that there's more chronic inflammation, which involves the innate immune system. And this chronic inflammation increases with time, but they're not continuous processes. We see that acute inflammation is actually episodic, but we also see that chronic inflammation is episodic. It tends to increase with time, but progression of symptoms does not occur in a steady, straight line getting worse. There are periods of time where people will have worsening of their symptoms, and then they'll have periods of stability or even regression of their symptoms where they actually get better. The good news is if you treat acute inflammation early and aggressively, it seems to be able to either diminish or maybe even eliminate most of the chronic inflammation that leads to progressive MS. But for the people who have progressive disease, we need more. This year at ECTRIMS, Sanofi, they have a product, tolebrutinib. It's a BTK inhibitor. And they did two trials called Gemini and Hercules, and they reported positive results showing an impact on disease progression in both of these trials. Tolebrutinib is a BTK inhibitor. BTK stands for Bruton's tyrosine kinase. In B cells, BTK stimulates antibody production and B cell proliferation. In microglia, BTK promotes activation and cytokine production. So these are both pro-inflammatory effects of BTK. And we see that BTK is essential for chronic inflammation. The interesting thing is that unlike a lot of our current medications, BTK inhibitors can cross the blood-brain barrier. And that's going to be a really important characteristic for a drug to have an impact on chronic inflammation. There were two trials. One was in relapsing MS, where they compared tolebrutinib to teriflunomide. When they looked at the impact on relapses, tolebrutinib did not really do much better than teriflunomide. And teriflunomide we think of as a relatively weak disease-modifying therapy. And what about the impact on the MRI? We saw that tolebrutinib didn't do as well as teriflunomide in reducing new enhancing lesions or new T2 lesions. But here's the interesting thing. Look at the impact on disability. It had a positive impact on reduction of disability progression. They did another trial on secondary progressive MS where they compared tolebrutinib to placebo. And here, again, it showed a significant reduction in 6-month disability progression. This is a very encouraging result, and it does suggest that tolebrutinib may have a unique mechanism of action where it's going to have an impact on chronic inflammation and on progressive disease. So the second part of my talk, I shifted gears and I wanted to talk about anti-B cell therapy and some of the questions that we have about people who are on long-term treatment. We have a couple of dilemmas that we face, and we have these questions about how long people actually need to stay on anti-B cell therapy and whether it's ever safe to pause or discontinue treatment. There are some trials going on now where we're looking at whether or not a higher dose might actually be more effective. And at the same time, we're looking at extended interval dosing to see if actually going longer between infusions would be safe. And spoiler alert, we don't actually have any of the answers to these questions yet. We do have studies that sort of hint in both directions, but if you're on anti-B cell therapy, there's no algorithm to really tell us the answer just yet. There is some evidence that higher dose might actually be more effective. In the original clinical trial, where they looked at patients with progressive MS, they noticed that patients who weighed more and who therefore had a relatively lower dose of ocrelizumab compared to somebody who weighed less, those people had a higher risk for developing progressive disability. And so there are two ongoing clinical trials where we're comparing higher dose ocrelizumab to standard dose to see if it has a bigger impact on disability. The problem with that is that we might run into more side effects with higher dose. So far in the clinical trials, it doesn't look like that's the case, but I think you're going to need more long-term data to find out whether risks for infection and hypogammaglobulinemia are higher if we use higher dose. And on the other hand, less might be better. There have been several trials where they have looked at extended interval dosing, and here what you do is you start testing people's B cell counts somewhere around the 6-month mark, and then only when their B cells start coming back do you dose them with another dose of ocrelizumab. And so far, the studies that have been done seem to show a fairly minimal risk of relapses and new MRI lesions. In addition, we know that the longer that you've been on anti-B cell therapy in general, the longer it takes B cells to reconstitute. So people who have been on treatment for 5 and 6 years sometimes can go 9, 12, or even 18 months before we start to see their B cells coming back. But before we can make any conclusions, most of these have been smaller studies and of relatively short duration. The longest that I know of is a 5-year clinical trial. But in that trial, they didn't look at the impact on disability progression, which is one of the most important things to look at. And what about stopping treatment altogether? In one of the trials that was presented at ECTRIMS this year, they looked at whether or not it was safe to de-escalate from a high-efficacy treatment, and they found that whenever patients went to a less effective treatment, their risk of relapse went up. But on the other hand, there was a big trial that was done at Rocky Mountain MS Center where they looked at 1,264 patients, and they did a 2-year study, and they looked at the risk of relapse as people got older, and they compared high-efficacy treatments to lower-efficacy treatments. And what they found is that the high-efficacy treatments had a clear benefit for younger patients, but once people reached the age of 54 years, it looked like there wasn't a clear benefit for high-efficacy treatment. So in this study, it suggests that it might be safe to de-escalate as people got older. So we have conflicting information about whether or not it's safe to de-escalate or whether we should stay on high-efficacy treatment. My approach has been basically to keep people on every 6-month dosing with anti-B cell therapy, or if it's Kesimpta, on every 1-month dosing, simply because I don't see an advantage of extended interval dosing unless there's a clear safety benefit. I make an analogy to changing the oil in your car. You could probably go, an extra 5 or 10,000 miles between oil changes. So that would be like extended interval dosing. right? But the problem is over the lifetime of a car, that could make a difference in the engine. And that's my concern about extended interval dosing, is that if we do that over many years, it may not have as big an impact on disability progression. And like I said, we just don't have the answers, but there will be more to follow. So if you've made it this long, thanks for watching. And I'll finish up with a few outtakes, because I noticed that a lot of people on YouTube like to finish their videos with all the mistakes that they've made in their presentation. So I don't know that there are any good ones, but I'll stick it on at the end here. And again, thanks for watching. The first thing that I want to do is help. Oh boy. Okay. The first thing I want to do is, these will be good for the outtakes. A movie of a brief. Right. Again, here's everybody. More outtakes. That's great. After going to the meeting in Stockholm, but going to the meeting in Copenhagen. Let's try again. There's antibody production and B cell proliferation. What is this try? What is this? Can't back up. It's because it's recording. So I got to start this slide over.